So we're going to be dealing with the unhappy patient. First of all, I would like to congratulate Dr. Huda for trying to arrange these sequenced presentations in a way that the first speakers would kind of recommend the multifocals, and then I will talk about the unhappy patients. The unhappy patients, I had few of them coming to me in the past years. And surprisingly, the physicians, some of them, when they refer them, they say, well, everything is fine. The patient absolutely have a psychological issue. So and knowing more and more about the trifocal, I think those physicians would know that they are the one who are not appreciating that this is a true problem. So we have to know, is it a rare event? The FDA trials have seen a few of those a series of multifocal IOLs, and they reported that 94 to 97% would recommend it again, would do it again, compared to only 88%. But other studies, as we review the literature, we've seen that 25% of patients were unhappy somehow. There are main factors and causes for the unhappiness, as were mentioned previously. Some of them are really simple and can be addressed with the preoperative exam and postoperative exam. That would include the dryness, the residual refractive errors, and other phenomena, and we will address this later in the presentation. So what are the visual compromises that the patient would come complaining of? Basically, he will say that I'm not happy with the vision. Some of them will be that vague. They will not tell you what exactly. They will say it is foggy, they will have the halos, or sometimes they will complain of the dysphotopsia phenomena, which could be negative, like they describe an arc-shaped shadow in the temporal field of vision. And we've heard this complaint even with after monofocal, after in the bag posterior chamfer IOLs. But most of them will complain of the positive dysphotopsia, which is the halos and grays and glare and streaks. The apparitions in the general, as Dr. Mohanna mentioned, or Dr. Anand in previous presentation, there are the 6 types of optical aberration that could happen, whether astigmatic, chromatic, and any of them could affect the vision of the patient. And basically, the principle of it that now we're not having the rays are focused on one focal point, but rather they're going into space, creating that optical chromatic aberration, for example. So in order to avoid most of these complaints, as much as we can possibly do, is to plan a very good preoperative planning, and that is choosing the right candidate, as we're going to mention later. But I would say that it's important to know that if you are the right surgeon to do those lenses or not, you need to have the right knowledge. Once you have a procedure that you want to do, at first, any kind of procedure, you need to know that you have the right knowledge from the type of lens or the type of procedure till the complications you will face and how to deal with them. Once you have the right knowledge, you need to be patient. You need to know how to deal with those patients. You need to be calm. Some patients will come frustrated and just rush into your clinic just to get their anger on you. You need to understand that their complaints are accurate. They're not just complaining because they are not happy with something simple. No, it is a daily complaint that they suffer from, and you are willing to deal with those unhappy patients. So if you see that in yourself, then yes, go ahead and implant those multifocal lenses. In many of the reviews I have seen, they usually talk about preoperative counseling or talking to the patient, and then they talk about the preoperative examination. But I think it is the opposite way around, where we need to address the examination, and then once everything is fine, then you can counsel your patient and talk to him about it. So you have to be convinced first that this is the ideal procedure for your patient. An examination, examine the patient if you're doing refractive surgery for him. So you have to make sure that the ocular surface is fine, the cornea, the topography, the astigmatism, the retina, as was addressed by Dr. Osama, epiretinal membranes, the glaucoma, do you have zonular weaknesses, and any systemic disease that will compromise the quality of vision. the IOL biometry, which kind works better with your kind of multifocal or trifocal IOL you've choose, the formula factors, and so on. Then the part of counseling comes. You need to talk and talk and get to know your patient. It becomes with experience easy to know the patient personality, occupation, and hobbies. Understand the patient goals after surgery. It's not just your goal. We're educated people and we look at near as very important, but some people really don't need that much near, so we have to know what they really need. You have to have realistic expectations as well as your patient. And you need to know, and your patient needs to understand that monofocal lenses are not necessarily inferior to premium lenses. They're, the option of monofocal vision and the monofocal correction, the glasses and everything else is fine as well. So the patient may be trading a bit of visual quality for flexibility, and he needs to understand that before he goes to the procedure. But sometimes you will have this perfect surgery, perfect candidate, but still the wrong patient, and here comes the preoperative counseling, and it's an important thing. Intraoperatively, the perfect cataract surgery, nothing less than perfect cataract surgery, would help in achieving your goal, especially with the premium IOL implantation. Post-operative period, you shouldn't become defensive or dismissive of your patient. The crucial to listen and to understand. Some problems are really simple and easy, and patients would just, if they have been offered or have been explained why they were offered this solution, they would be much happier. But you need to kind of listen to them and see what are the specific complaints so you can address that complaint. The duration of timing, so you would know, is it related to something that can be, that happened sometime after the implantation or immediately after that. And then the management of these problems. So address the ocular surface. If it's dry eyes, treat it. Even if after you do the surgery, discover dry eye, still you have to treat it. If you're planning for further enhancement or refractive surgery, address that carefully. Residual refractive errors, you have options to deal with that. If it's a high spherical refractive error, then an IOL exchange or a secondary piggyback IOL can be an option. Laser refractive surgery or an astigmatic keratotomy if there is a plano spherical equivalent. The ideal time is about 6 weeks. You can go longer than that if you want to make sure. If you have a multifocal toric IOL, then maybe you can do it a week or two later on just to make sure that the lens won't move afterwards. Posterior capsular opacification, it's a tricky decision because you don't want to go ahead and do this YAG capsulotomy before you are sure that this is the real complaint of the patient, as at the end you may need to exchange the trifocal IOL. And here comes history. If you have a clear posterior capsule first postoperative period and the patient was happy, and then when he developed the PCO, he was unhappy, then you can know what are that it is the cause. And the type of complaint is also important. Cystoid macular edema that could happen needs to be treated carefully and fully. Make sure preoperatively that there is no epiretinal membranes. And then we come to the unwanted visual images that create a little bit of a challenge for us. Most of IOL recipients have unwanted visual images, but they suppress them, and we always tell them that this is the process that we call neuroadaptation. So this neuroadaptation for near and night vision may take 3 days to 6 months. We try to help them maybe at the beginning if it's bothered them by reducing the nighttime pupil size using Alphagan. It's helpful in some patients, but it's not helpful in others. We need to understand what is neuroadaptation. The stereopsis is a chronic glory of visual evaluation. The brain of humans, they take the image, they achieve a single from each eye. They take one image and they achieve a single unified picture rich in depth of perception. What we have done as ophthalmologists, we have made this picture a bit more complicated. So we moved to the presbyopic IOL correction, where we have not one image for one eye, we have different images, and these images variously focused and defocused within a single eye. So the brain of the human is not used to this multifocality and doesn't know any experience of it. So what you have to do is, what the brain does is that it tries to neuroadapt to this process. And this is a challenge, a visual challenge that will take few days in some people and will take few weeks or never adapt to it in some people. The last resort that you would do is the IOL exchange. And most of them are related to those unwanted images, intolerance to glare and halos. But before you do the IOL exchange, it may be just give the patient a trial of a -3 lens, just to let them see what it would like if they want to have reading glasses for later on. So in the pearls of handling dissatisfied patients, when you enter the room and you know that your patient is not happy, be prepared, have your refraction, OCT, topography, everything you need. Address the complaint immediately. Don't try to ignore it or just don't give it a perfect understanding. Formulate a list of solutions for the patient's problem. When the patient surgeon relationship has reached a selling point, as Dr. Osama mentioned, refer him to a better surgeon who will do the thing. And actually, that better surgeon would be a patient who is more, a person who is more compassionate and can talk more and deal with this kind of patient. Stay calm, listen to them, and find out the real objective and complaint and validate their complaints. So in summary, premium IOLs can provide excellent visual function and spectacle independence for great majority of patients. Some, however, will not be happy with their outcomes. Preoperatively, detailed history, examination, IOL calculation would discussion is critical to prevent the misunderstanding, and treat a premium IOL like you're treating a refractive surgery patient in the preoperative evaluation and the management afterwards. Thank you very much.